All right, good afternoon, everybody, and happy Father's Day for those who are going to be celebrating this weekend. I'm Gene Ransom. I'm the CEO of MedChi, the Maryland State Medical Society. I also happen to be the chair of the Episode Quality Improvement Program Advisory Council to the HSCRC. And very exciting today. We're doing the first in our specialty series to educate people on the new bundles that are available for EQIP for this year. EQIP open enrollment is coming up really quickly. It's going to start July 1 and go till the end of August. So it's important to learn about the opportunity and decide whether or not you want to be in it for 2026. So today we're going to be going through ophthalmology bundles, and actually very exciting because we've added ophthalmology bundles to the opportunity. Ophthalmology has been at EQIP for the last couple of years, and we've had some people who have been trying it and doing it now for 24, 25, and will obviously be in 26. And this is the first real expansion of ophthalmology that we've had since we first added a few bundles for that. So really good opportunity to learn about it. For those of you who don't know the history of EQIP, essentially the Episode Quality Improvement Program is something that was created under the unique Medicare waiver that we have here in Maryland. Initially, we had a couple value-based care programs around primary care, particularly the Maryland Primary Care Program. So, which obviously MedChi strongly supports because we love our primary care partners. But we pointed out that we want to have an opportunity for all physicians. And the great thing about EQIP is literally all physicians can participate in it as long as they have a triggering episode. So today we're going to talk about ophthalmology, and I'm going to turn it over to Olivia Simon to go through the EQIP ophthalmology opportunity for program year number 5. Olivia, it is all yours.
Thanks, Jean. Hi, everyone. Thank you for joining us this afternoon. As Jean just mentioned, MedChi is hosting these series of EQIP specialty webinars to go through some of the opportunities for Performance Year 5, calendar year 2026. So last week, we did kind of an overview of the program and talked about all of the new episodes. Today, we are going to focus on the ophthalmology episodes, and then we will have 3 additional webinars in the upcoming weeks. So let's get right into it. So Jean gave a brief overview of the history of EQIP. And so I just want to echo what he had mentioned. So essentially, as a result of the total cost of care model, Maryland practitioners were left out of national Medicare value-based payment programs. And so back in 2022, the Health Services Cost Review Commission, or the HSCRC, created this voluntary episode quality improvement program known as EQIP to give Maryland practitioners the opportunity to participate in these value-based care programs. And so we are currently going into the 5th performance year in calendar year 2026 of this program. So EQIP is a completely voluntary program, and it is also an advanced alternative payment model that is offered to Maryland generalists, specialists, or other CMS-approved practitioners. EQIP will engage its participants who treat Maryland Medicare beneficiaries in care transformation and value-based payment through an episode-based approach. So essentially, by participating, you will be held accountable for achieving both cost and quality targets for one or more clinical episodes. And so today we will review those episodes specifically for ophthalmology. Before we get into that, though, I did want to take a moment to point out again that EQIP is an advanced alternative payment model. So CMS's quality payment program has 2 different tracks. The first is the merit-based incentive payment system, or MIPS. And then the second is Advanced Alternative Payment Models, or AAPMs. EQIP falls under this AAPM track of the quality payment program. Therefore, practitioners who participate in EQIP are on this AAPM track and are considered qualifying APM participants, or QPs. The reason I want to point this out is because QPs are exempt from MIPS reporting and MIPS payment adjustments, and they will receive a higher Medicare physician fee schedule update than non-QPs. Currently, At this time, this update is set at a 0.75% qualifying APM conversion factor. This is set by Congress, so it is always subject to change, and we will communicate if there are any changes. But right now, this is a 0.75% qualifying APM conversion factor. So the reason I want to point this out again is because by being an EQIP, you would be considered a QP. This is not dependent on your performance within the program. These two things will occur because you are involved in an AAPM. So how does EQIP work? I've broken it down into three main buckets. So looking at the first one, we have this annual enrollment opportunity. So that's what Jean mentioned, upcoming in July. So during this enrollment opportunity, practitioners can enroll in EQIP entities, which consists of one or more practitioners, and then they will select those clinical episodes that they would like to participate in. And there are some volume criteria to be able to select the episodes that we can talk through if you are interested. But it's really up to the participants to decide which episodes they would like to select as long as they meet those criteria. Then the target price is set. So what will happen is EQIP will look at the cost from episodes triggered in EQIP's baseline year, which is calendar year 2019, and then a per episode average cost or target price, goal price, is assigned to each EQIP entity. Lastly, the performance in the program is assessed. So EQIP uses claims data to assess both the cost and quality performance of its participants. Those performance year episode costs will be compared to that target price that is set. And if there are savings, an incentive payment will be due to the EQIP entity. And we'll get into the details a little bit more. So starting with what I had mentioned first is during that enrollment period, the entities are going to select those clinical episodes that they would like to enroll in, and that is based on their baseline volume in calendar year 2019. I'm going to show you the episodes on the next slide, but before I do, I did want to break down the different components that make up each episode. So first we have a trigger. The trigger is the ICD-10 code, CPT code, or HCPCS code that initiates the start of an episode. These codes indicate that a patient has a particular condition or underwent a particular procedure. So again, this trigger is through claims data. Then there is the look back window. This is the time period prior to the trigger when all of the costs relevant to that trigger are counted. And then there is the close period window. This is the time period following the trigger event when all of the costs relevant to the trigger are also counted. So for performance year 5, calendar year 2026, there are 123 different episodes that are going to be offered to participants. And you can see here they are organized by clinical categories. I do just want to note that these episodes are organized by clinical category, but there is no limitation to the type of practitioner that wishes to enroll in EQIP under these specialties, or excuse me, under these episodes. So again, your episode selection will depend on your volume in calendar year 2019. And if you are interested in participating, we can help you figure out which episodes you would qualify for. So today I wanted to focus on the ophthalmology episodes. So as Jean mentioned, ophthalmology did exist in prior years, but we only had 2 episodes. So we had cataract surgery and glaucoma. Now for performance year 5, calendar year 2026, we have added 3 new ophthalmology episodes, and you can see them listed on the screen here. What's currently being developed is the episode playbook that will include those episode triggers and the episode lengths that I had just talked about that make up an episode for these specific ophthalmology episodes, along with the other 123. That's being developed right now. When that becomes available, you will be able to look through this playbook and find the specific trigger codes, find the episode lengths and other relevant codes and associations that are included in these episodes. For the time being, though, I did want to show an example of one of the new episodes and show you kind of what we mean by their trigger codes and establishing an episode length so you can get a better understanding of how these episodes will be broken down. So I'm going to show you an example today for macular degeneration. So here you can see on the screen the trigger codes for this particular episode. And again, each episode will have unique trigger codes. These codes will indicate that the Medicare patient has this particular condition and then will initiate the start of an episode. So when you bill the following codes, that is initiating the start of this particular episode. Then for the episode length, you can see an example for, again, macular degeneration on the slide. Once that episode is initiated through claims data, the episode length will be used to determine the total episode cost for that particular episode. So here you can see in the middle is the episode trigger. So this again is the submission of the ICD-10 code. And then the look back period is the time period prior to the trigger event. So for this particular episode, it is a 30-day look back period. And then the closed period window is the time period following the trigger event when all of the relevant costs will also be included. So for this episode, the closed period is till the end of the study period or the end of the performance year, the end of 2026. So from 30 days prior till the end of the calendar year, all of the relevant costs associated with that episode trigger will be included in the total episode costs. So the total relevant costs for a single episode include all Medicare Parts A and B claim payments for the beneficiary for services that are rendered within that episode length and considered relevant to the episode. So typically those relevant costs are either services or costs that are clinically associated with the condition or the treatment of the episode, and this is regardless of who provides them. So you can see a few examples of what's typically included in these relevant costs on the slide. As I mentioned, the episode playbook is still under development. Once that is available, you will be able to find more information on all of the trigger codes, all of the episode lengths, and some of the relevant costs, including the associations or relevant diagnosis codes and or prescriptions with those particular ophthalmology episodes. So that is to come. These episode triggers and all of the relevant costs are derived directly from the Medicare fee-for-service claims. So the really nice thing about EQIP is there's no additional reporting requirements for participants. So you don't need to be doing any extra work to track any of the episode triggers that you're triggering it or the costs related to them. EQIP is using claims data to do all of this for you. So in order to determine if you are able to generate savings within those episode categories, each EQIP entity is assigned its own unique target price per episode it has selected. So in order to do this, EQIP goes back to the baseline year, calendar year 2019, and it looks at the average total relevant episode costs for all of the episodes that were attributed to its care partners during that baseline year. I do want to point out that EQIP's baseline period is 2019, but in performance year 5, the emergency department episodes will use 2023 for their baseline period. But for everyone else, it's 2019. That is how the target price or goal price is determined for the entity. The preliminary target will be available at the beginning of the year. However, the final targets will be made available at the end of the year after inflation adjustments and other standardization have been applied. So again, in order to determine savings, those performance episode costs will be compared to this target price. And that is how the entity will determine if they generated savings or not in the specific episode categories. In addition to trying to generate those savings, there's also a quality aspect to EQIP. So there are three quality metrics for EQIP. The first is advanced care planning. Then there's documentation of current medications in the medical record and BMI. So essentially what will happen is for each attributed episode, the HSCRC will assess to see whether these three quality metrics were performed by any practitioner within the year preceding the end of the episode period. So a few things to point out here. One, these metrics are also measured through claims data, and they are only measured through claims data. So if you are tracking quality metrics through your EHR, they would not count towards EQIP. I do have the specific submission codes on the upcoming slides, so I can give you an idea of what I'm talking about here, but I just want to make it very clear. These metrics are measured through claims data. Also, these measures only need to be billed once by any practitioner to receive credit. So what that means is any practitioner who sees that Medicare patient within the year preceding the end of the episode period can actually satisfy your requirement for the quality metrics. So for example, if you were attributed an EQIP episode and that patient went to their primary care provider within the year preceding the end of the episode, and their primary care provider completed advanced care planning and billed the appropriate submission codes, that would actually satisfy your requirement as well. So here is some more information on the advanced care plan metric. I'm not going to read through all of this now. This will be available in the slide deck that I share and the recording, so you can feel free to go back and read into these. I did just want to point out again the submission codes. So for advanced care plan specifically, there's one of two submission codes that would need to be billed to get credit. I believe one of them is that the advanced care plan was documented, one was discussed but not documented. So there's two different options that would both satisfy. Same thing with medication reconciliation. There are three potential submission codes that would satisfy this MedRec requirement. And then lastly, for BMI, there are 5 potential submission codes again that all differ a little bit, but these codes all satisfy this requirement. So now I'm going to talk about the incentive payment methodology, maybe the most important or interesting part of this. So I've broken it up into 5 different pieces. The first part of determining if you earn an incentive payment based on your performance in this program is to analyze the performance period results. So at this time, those performance year episode costs will be compared to the target price. And if those episode costs are less than the target price across all episodes in which the entity participates, you get a check mark and you get to keep moving through this methodology. That's step number 1. In addition, we will check to ensure that at least 3% of savings are achieved. This is to ensure that the savings are considered statistically significant. Once you get a check there, you move on to the next bullet. If there are any dis savings from prior years, they must be offset. So I'll talk about the dis savings policy a little bit more on the next slide, but a part of this policy does say that if an EQIP entity has dis savings or negative savings, meaning their episode costs were actually greater than their target price, they would have to offset those dis savings from the prior year before moving forward within this incentive payment methodology. So that's step number 1. Then we have number 2. This is a shared savings program. So what that means is each entity will share its savings with Medicare. So each care partner's target price is compared at the state level and ranked on efficiency. So our lower cost practitioners are in the higher tier and higher cost practitioners are in the lower tier. In that highest tier, you can see that 80% of the savings will be due to the entity, while 20% will be retained by Medicare. And then on the lower end, you can see that 50% of the savings would be due to the entity and 50% would be retained by Medicare. So that's step number 2, determine the percent of the savings that the entity would get to keep. Then we move into the clinical quality score. So whatever the incentive payment amount is at this time, 5% of that will be withheld pending quality assessment. So essentially what will happen is for those 3 metrics, EQIP will look at the performance rate that those 3 metrics were performed for those EQIP episodes that the entity was attributed to. And based on how well they performed those metrics, they will get to keep up to that full 5% of the incentive payment that is being withheld pending quality assessment. So if they score really well on the quality, maybe you keep that full 5%. If you're somewhere in the middle, maybe you get only 3% back and lose 2%. So that's where the clinical quality score comes into play. Then there's the incentive payment cap, which isn't super important right now, but I just want to note there is this incentive payment cap. So we just need to check that the entity does not exceed the cap. And then lastly, the final incentive payment at this time will be paid directly in full to the payment remission source that is indicated by the entity during the enrollment period. This is paid again in full, approximately 9 to 12 months after the end of the performance period. So there are a few reasons why an entity or care partner may be removed from EQIP, but I wanted to focus on 2 specific policies. So as I mentioned on the last slide, there is that DIS savings policy. So the great thing about EQIP is the risk is not taken at the practitioner level. There is no risk. You are not going to be penalized for having poor performance within this program, but these policies do exist to try to continuously improve performance. So the DIS savings policy, the first part I mentioned, there is that if you have DIS savings in a prior year, you would have to offset those DIS savings before moving forward in the incentive payment methodology. But if you are in the lower 2 terciles of that tiered shared savings rate from the last slide, and you have 2 consecutive years of DIS savings, you would be removed from the program for 1 year before being able to re-enroll. There's also this catastrophic quality performance policy that says if your performance rate for one of the quality metrics is below the 20th percentile benchmark, you will receive 0 points for that measure and be on probation, and 2 consecutive years on probation will result in automatic exclusion from EQIP. Again, that's sitting out 1 year before you would potentially be able to re-enroll in the program. So the last thing that I will end on is, again, just this upcoming enrollment opportunity. So performance year 5, calendar year 2026. Enrollment for that year will officially open on July 1st, and it will run through Friday, August 29th. During this time, you will have the opportunity to enroll in EQIP. And Jean and I are here to help you figure out if this is right for you. My contact information is on the second slide. There's also the EQIP inbox that you can always reach out to for more information. If you're looking to see if you qualify, we can run your MPIs and determine which EQIP episodes you are able to participate in. I also want to mention that there is an open enrollment webinar that will be taking place next Wednesday at 12 p.m. This will kind of walk through more of the logistics for enrolling, but you're welcome to attend that webinar next week. The registration link is also included in this slide deck. So that includes the presentation for today. Thank you again so much for joining. And Jean, I'll turn it over to you for any last words.
No, but why don't we open it up and see if anybody has any questions?
Certainly. Any questions?
So when will the PY5 episode playbook be available? They are releasing them as they complete them. I think right now we have, what, 1 out? Is that right, Olivia?
Yeah, I don't have a great date for you on that, but we will keep you updated as soon as we do have those materials available.
Any
Anyone
other?
else?
All right. Well, thank you all for participating today, and feel free to reach out directly if you have any questions or need anything.
Yeah. Thanks, everyone. Have a great weekend.